Welcome to Health System CIO's interview with Dr. Priti Patel, CMIO at Muir Health. I'm Anthony Guerra, founder and editor-in-chief. Dr. Patel, thanks for joining me today.
Thanks so much for having me.
All right, very good. You want to start off with a little bit about your organization and your role?
Sure. My name is Priti Patel, and I'm a family physician and chief medical information officer at Muir Health. Muir is a health system, independent health system based in the San Francisco Bay Area in a town called Walnut Creek. We have two acute care hospitals, a behavioral health center. We have about 1,200 affiliated providers, 80 clinics. And we are based in a couple of counties in the San Francisco Bay Area.
Okay, great. So we're here, not surprisingly, going to talk a little bit about AI. Shocking, right?
Yep.
So we're just trying to, I'm talking to different people. Just would like to know sort of what you're up to, where you're focused in this area, where you see the main challenges. I'm certainly have things that I'll bring up here and get us a little more focused. But wherever you want to jump in, sort of, what are the main areas that you're trying to leverage? And when I say this technology, I know there's a variety of AI technologies out there, but just wherever you want to jump in, and we'll go from there.
Sure. So, we've been doing AI for quite some time. We've been doing a lot of work in predictive models. So, predictions around clinical deterioration in our inpatient units. We, as part of some of our opioid task force work, have a opioid risk score. We've been focusing on readmission, so predicting, who's more likely to need that follow-up care and to sort of prevent a readmission. So that's been our course up until in the last 2 years when generative AI really came onto the scene. And since that's happened, we've been implementing a lot of different generative AI in many different settings. I'm a primary care and urgent care are my areas, and so naturally it makes sense to move into the areas you know best. And so we started off with ambient AI scribe in our ambulatory practices. This was about 2 years ago now. And now all of our physicians in the ambulatory setting are able to utilize ambient AI for their visits. And that's led to a lot of amazing reductions in sort of time spent after hours, really improve the patient visits. The patients really like it. We've had just a lot of great success, and it's definitely a tool that we're going to keep in place. In fact, this week we're rolling it out more broadly on the inpatient and ED sides. Our focus has really been around reducing the documentation burden for the physicians, but we're looking at nursing, case management, nutritionists, our rev cycle team. I think our rev cycle team spends a lot of time drafting letters for denials appeals, prior authorization. So our initial focus has been and continues to be really around reducing the administrative burden, but we're also now turning our attention to some of the automations and AI agents for our call centers to really kind of think about, how can we leverage, at least for some of the simple tasks like scheduling medication refills, can we use voice agents to sort of improve access and facilitate some of the care there.
Okay, lots of stuff there, lots of stuff there. So I'm ready to dig into some of that. So a couple things here. Let's talk a little bit about usage. You mentioned that they're able to use it, and one of the issues is usage. How to promote usage and adoption. Um, that's obviously a goal. I guess we want everybody using it as much as possible. What are your thoughts around that? How are you handling that, sort of monitoring it and trying to expand it?
So I think when we first started, there was a lot of enthusiasm. So we had about a third of our doctors really wanting to utilize it. It didn't take very much to get the adoption that we were hoping for. And then we've taken a different approach with the remaining two-thirds. So that kind of middle third required a little bit more introduction to the tool and what benefits that we have seen. So we'd have to sort of share, kind of what their documentations times were like compared to those people who were using ambient scribes. So sharing data really helped them understand why it might be something to introduce to the way they do things. So I think adoption is something that's still going to be really important. You know, it's a with any technology, the end user requires the why, the support, and then the ongoing sort of feedback on how things are going. So we're taking the same approach with AI. I think what's a little bit different about AI is that people are so enthusiastic about it that you have these people who will just, are happy to utilize it in any form. It's like they're just ready to get started. So that's been one of the really nice things about the AI implementations that we've been doing. And I think some of the things that are coming soon, so chart summarization, there's all kinds of tools that we're implementing both through our ambient scribe vendor as well as in our EHR, where it will start looking through the medical record and bringing forth relevant information, so that way it's easier to identify things that are of importance to the patient, and kind of key findings that one should know about when evaluating patients. So I think that's going to be helpful for not just the physicians, but nurses, staff, really everyone. So I think that's going to be a real win, and it's not something that is going to take, at least I don't think it's going to take too much effort around adoption, as long as the solution works well.
Yeah, so that's interesting. Sometimes it's the idea that you have to do a lot of work to get adoption. And in this case, with the majority of users, they're enthusiastic, so they may jump on it. Um, and we could get to the point with this technology where it's the outliers who don't want to use it, who you feel now we have to get them to use it. So, for example, the technology becomes almost stakes to play to provide proper care and to operate efficiently. And at some point, not using these kind of things is not going to be okay. Does that make sense? Looking down the road?
Yeah, and I think the way we're framing it is, I think they're really going to miss out on some of the great benefits of this technology. We've been on the EHR for more than a decade, and I think there are folks that use the fancy tools that are built in, and then there's people who just kind of use it as almost like a word processor, and they've been managing all along. But I think AI really accelerates things, and if they don't really lean into some of these tools, those people who are using these tools are going to be farther ahead, gaining a lot of efficiencies, improvement in quality. So now it becomes really important that we bring those folks along, the folks that are a little bit less, willing to take on new technology and change workflows.
Yeah. So does some people are saying that AI, the nature of these tools requires a whole new approach to training and education. Some of the vendors should take on some of that responsibility, but certainly the health systems as well. Also, that using these things, and depends on what we're talking about, but if we talk about the generative AI, where you do have what they call, I'm sure you know these terms, drift and hallucinations and all these kind of things. It requires a different approach to training and education for a couple of reasons. One, that you want your users to understand that they're not perfect and that sometimes they may, one of the one actually in the GPT-5 release, what I read is it's supposed to now tell you if it doesn't know something. And that was the biggest problem, that it wouldn't just say I don't know. It was like embarrassed, if we anthropomorphize it or whatever you want to call it. It was too embarrassed to tell you I don't know. So it would always give you an answer. And that was one of the problems because it always sounded confident. Anyway, these some of these subtle things, does it require a whole new level of training and education?
Yeah, I mean, I would say that it does to a degree. I think people need to understand how the tools that they're using work. So we have been doing some training around, just basic fundamentals of AI. Like what is AI? What is the type of AI that we're using? How does this work? How do these the and it's really around creating text, like how is it doing this. I think that's the part of just it's basic training, and I mean I do think that we need to do a lot more as time goes on and these tools become much more advanced. But I think right now, all the tools that we're using require human in the loop. So,
Mm.
having that person understand, how this output's coming to be, and then taking that responsibility of reviewing it and editing it because they know that it's not perfect. I think that's really key. So we do continue to emphasize that as we start rolling this out more broadly to people beyond the physicians. I mean, we're utilizing this in our in baskets for our physicians, and so I think that's where the tool will produce an output that doesn't always match what the physician wants or desires, and so there's this iterative feedback that we're constantly giving of improving the tool, but also I think people understand that it's not going to be perfect, and we're going to keep optimizing it. But there's a huge responsibility for the physician to add to it and make sure it's accurate as possible.
Right, and one of the metrics I've seen people are looking at is how often, for example, does a physician edit the output? And if it's almost never, then that that needs to be
Yes.
addressed, right? So you kind of get these interesting metrics people are starting to look at.
Yeah, we are doing the same.
Yeah. So hey, you're approving 98% of everything it spits out. Like maybe you want to give it a closer look. So lots of fun stuff there. All right, very good. Um, You mentioned, rollouts and getting broader with rollouts is a huge issue now with pilots, because of there's so much new technology. So there's so many things to try and experiment with. There's all different ways to do pilots. There's a thing called pilot fatigue, doing too many pilots. Somebody told me the other day they don't like the word pilot. They like phase rollout, and little subtleties here and there that sometimes are just psychological advantages, or sometimes it technically have to do with the rollout. But I guess the idea is we want to try things. We don't want to throw good money after bad. We want to, they said fail fast, that kind of a thing. But we're dealing with busy users here who they don't need to be thrown things and then say, ah, never mind, we're going to try something else. Like there's a cost to trying these things. So what are your thoughts around those kind of issues?
Yeah, I mean, that's a really important topic, and we discuss it all the time because I think some of the new technology, and I think a lot of this is AI now. Some of it is mature, and then a lot of it isn't. And I think the AI that we've been utilizing. I'd say the breakdown is 25% feels like it's fully baked, and then the 75% it's pretty good. It's improving, and it improves very quickly once you start it. But I think one of the lessons that we learned with one of our rollouts is that we thought the technology was going to work better than it did, and when we involved a lot of folks in that, we had a lot of people who dropped out, people who I thought would be really good at utilizing this technology, and I wish that they had stayed with it. But I think their initial experience was was negative, and so then we lost their level of interest and engagement, and then it's been very hard to get that back. So I do think that if the technology isn't as fully developed as you'd expect it to be, then it's better to start off with the pilot. Pilots are very resource intense, time intensive, and require a lot of collaboration between teams, and they can go on for quite some time. So I would say that you can only do a certain number of pilots, and so we're trying to limit that number of pilots just to stay within our the amount of resources that we have. And then for those technologies that have been tried and true, have been implemented at other organizations successfully, those are the ones that we don't want to sort of pilot it. We just want to go forward with it so that way more people can really benefit from it. And it's just kind of it's simpler and more streamlined to be able to do a broader rollout for technology like that.
There's a lot of good stuff in what you just said. That whole example you gave about having people who were on board and excited, and you lost them, because I guess the technology they tried it and they were just this isn't for me. Somebody else mentioned that to me the other day. This concept of momentum, and that if you lose it, it's very hard to get it back. And that really is a takeaway that's super important, right? So we have to be careful, and I'm putting words in your mouth, I'm just putting thoughts out there. We have to be very careful about the pilots. A pilot is not a small deal. It is a big deal, as you alluded to. It's a big, it sounds like a little thing, right? Because that's what we want it to sound, but it's a big deal. And these users that are willing to engage with us are worth their weight in gold. So we have to be super careful with their time, and we have to do a lot of legwork ahead of time to make sure, a lot of vetting to make sure that we really, really think that they're going to like this. Because if we do it lightly and we throw out a tool that they don't love, they might say, "Hey, you know what? I don't have time for this. You gave me something. It wasn't great. I can't do it." It's hard to get them back. So big lessons in there, right?
Yeah, yeah, and, I think and then you lose that trust, so then, when you try to roll out the next technology, they automatically think, "Okay, is it like the last experience, or will it
Right.
be different?" So
Right. And the other thing you mentioned about wanting to, there's different types of organizations. There's in health systems, the bleeding edge with the innovation centers and a lot of money, and they can try all kinds of different cool things. And then there's organizations that are happy to follow those people and make sure, as you said, it's vetted, it worked there. Show me where it worked, right? Show me where it worked. I don't want to be the place that tries to figure out if it works. Not everybody wants to be an innovation partner to a startup. Maybe some do, maybe some don't. What are your thoughts on understanding as a health system where you belong on that scale and engaging appropriately?
yeah, we are a community-based health system, not an academic center, so we don't have an innovation center. But I will tell you, a lot of the folks that work for John Muir have an innovative mindset. So we will take, depending on the need and the business strategy, we will take on innovative projects. So, like our ambient scribe implementation, we were one of the first in the country to do that. And so, but that was, something that we had really focused on. We really wanted to address, our issues with burnout and documentation burden. So we did take that on as a very innovative project. But, when you think about, can we do 10, 20 innovative pilots and projects? That's just not possible for an organization of our size and scale. So I think that's when we start looking toward, what are the academic centers doing? What are those health systems that have innovation centers? What have they implemented? What's really working? What outcomes are they showing? And the ones that, are successful, that's where we'll probably get into, like, not, we won't be on the leading edge, but sort of in that next category of folks who will get on newer technology, but knowing that it's been tested and there's value that's been demonstrated with it.
Right. So, in line with the idea that you have to be very careful and pick your spots, I think of governance and I think of having really good governance and making sure that, okay, we know what we have here. We know the money we have. We know the manpower we have or the people we have. We know our resources. We know what we can do, how we going to. Now, let's pick what we're going to do and let's make sure that lines up with the strategic objectives of the organization, so let's pick the right things. What are your thoughts on that governance process and getting that right?
I agree with that. I mean, I think that's how we sort of decide which technologies to implement. We start off with our health system strategy, what problems we're trying to solve, and then really look to see, what are other people doing in the space.
Mhm.
We're part of a lot of different organizations where health systems come together to share best practices and ideas. So we really lean into that through our networks to understand what our peers are doing, and then we'll oftentimes bring those technologies in to support some of our business goals. But I would say that, a lot of times there's so many amazing technologies out there, that there are some instances where someone will bring a really kind of neat idea and we start kind of the other way and sort of think, okay, well, what can we use this technology for? What potential use cases there are. So it's not that we don't follow that path, but I would say it makes more sense to start with the strategy and the problems in mind.
Yeah, let's talk about that a little bit because uh, everyone says everyone leans towards the side of focus on the problems you have and then solve for those. But there's something in me that says, and you mentioned it, you how do you not work a little bit the other way, especially when there's a new and amazing tool like AI? Now, I get the idea that I guess you could wind up a little off center, meaning you got this amazing tool, and one of the places it really works isn't quite aligned with your strategic objectives. So you're a little bit over here off to the side instead of working on one of these core things. It's all tough. I mean, as you said, I mean, there's a little bit of both ways on that, right?
Yeah, yeah, and I think even with tools that we have in place today or ones that we're rolling out for a specific purpose, oftentimes there's discussions of can we use the tool for this or
Mm.
that, and and it's something that the vendor may not have considered. And then depending on the vendor that you're working with, sometimes some of them are willing to innovate in that space, and then others you kind of place a ticket and you wait for the development to occur. So I would say, it can like we are oftentimes thinking of using technologies for to solve other problems. Um, and but I would say that that's starting where, you're just taking something that's, that just seems really kind of neat and fun. And,
Mm.
like how do you match that up to something that you
Right.
really have going on? And trying to get the funding for that is sort of a whole other separate thing. It's like who's willing to take the risk and, should we bring something in just because it seems like it might be a good idea or something like fun to innovate with.
Right, right. Let's talk a little bit about the bots you mentioned, or the agentic AI bots, whatever you're deploying in a call center type scenario. If you want to tell me a little bit more about that, from what I understand, conversations I've had, um, there's a couple of ways you can go in that area. One would be sort of build things out at a core level on your own if you have a real development shop. The other thing would be to work with more of a horizontal vendor that can put components together for you, and then perhaps working with more of an industry player that really knows healthcare workflows. What are your thoughts around the different ways, the different options health systems have in order to deploy bots and other types of agents?
I think we're kind of looking at our use cases. So, when, at least for our call centers, we're using, kind of your standard industry platforms. Um, and then those vendors are now developing AI chatbots that can then that can sort of or that are integrated with their current offerings. So that makes a lot of sense. And those are solutions that we're looking to. We haven't implemented anything just yet, but that's the plan. Um, but then there's this whole part of care navigation. So once a patient leaves one healthcare setting, moves to the other, as they're sort of moving beyond, like post discharge or, if it's before surgery, after surgery, I think that's where AI agents might be helpful in ensuring that, medications are received, there's follow-ups scheduled, all the things that patients may not necessarily focus on, but are really important to make sure that they stay healthy and they don't wind up with a complication or back in the hospital. So we're looking at some solutions that might be able to help with that follow up and care navigation. Again, we have not deployed this, but these are sort of things that we're thinking of. As either there's a human today that's doing a lot of this outreach, or it's just not happening, or it's happening in a text format, whether it's messaging through our portal or just out reminders that are automated, things like that. I think the like an AI agent that could interact with the patient to sort of help them if the other avenues haven't met the needs, then I think that's where there could be a lot of opportunity. Um, and then outreach, just simple, we've got about 80% of our patient population utilizes our EHR portal, which is amazing. But then there's the 20% that, we have to think about alternative ways to reach out to them. So, we've implemented secure texting, so that gets a certain percentage. But then there is a part where there's a portion where we need to call and really, have a human do this work. And so I think there'll always be a need for a human to do something, but perhaps some of that, the third channel could be an AI agent, sort of facilitating some of the more simple workflows.
Right, right. Very good. Question. We talk about a lot of everyone's comfortable with the administrative stuff around AI. Um, and not quite comfortable when we talk about clinical yet. Uh, but there's a line there. They blur into each other at some point? Is that something you think about? The fact that, we have to be, if we're okay with administrative stuff, some of this stuff gets pretty close to clinical, or is it a hard and fast line that doesn't get blurred, or is there some blurriness there that needs to be you need to be careful about? One of the other issues that is around what I'm describing here is this idea of medical device versus non-medical device, that some of these things start to dance towards that line, and when we get over that line, we need FDA approval. And even if a vendor says, "No, no, no, you don't need FDA. I don't need FDA. We don't need FDA approval. You're good." The health system has a responsibility to look at some of these things and say, "Well, you're pretty close to that line, and I'm a little uncomfortable because you're not certified as a medical device." Do you see those issues like kind of bubbling in the background?
Absolutely. I mean, I would say that there's a couple of tools that we're using today that it gives me I'm reassured that they are FDA approved. When you look at the AI that is sort of supporting the model, it is black box. And so when you get to AI of that level, I think it does require FDA certification to ensure that the outcomes that you're hoping to achieve using that technology really have been demonstrated in studies and other in other ways. Because I would say that as a non-academic center, we don't create any models in house, so we it's a buy strategy, and if we're going to buy something, it gives us that added level of reassurance if it's been tested and proven, and FDA certification is that next layer that gives us even more assurance.
Have you, and I'm not asking you to name names, but have you come across or seen or had any discussions where you thought they probably should have FDA approval and they didn't, or they said they didn't need it?
We are not running any clinical models today that should, in my opinion, need FDA certification. The models that we are running that don't have FDA certification, it's very clear what the inputs are. So it's they're fancy algorithms, but you can still see the inputs into the algorithm.
Right, so it doesn't have that black box dynamic that you talked
Yeah,
about. Yeah, and it's funny when you hear from the CEOs of the large language model companies that say, "Yeah, we kinda don't know how it works either." Right? I mean, they say
yeah,
things like that, that, "Yeah, we
right.
we don't know exactly what's going on in there, but it's spitting stuff." So, just a final question, anything I'm missing, that you think that either you're working on or you think is important for people to be thinking about? Maybe something you've come across or it's in the back of your head, either as a concern or whatnot, and you just wanna bring people's attention to it, or just a final piece of advice.
Yeah, I think when we've rolled out technology in the past, it's been very focused on the staff and the providers. Um, but AI requires a lot of education on the patient side. So that's been a real learning for us is, how do we bring the patients along in the journey? Because they're receiving all the same news that the rest of us are. And they know that we're utilizing AI because we're disclosing and we're very
Mhm.
transparent with them. And that level of transparency then brings up a lot of questions. So we had to really prepare our staff and our providers to be able to answer these questions in a way that, patients would understand. So first, the physicians need to understand, the staff needs to understand. So we've done a lot of work around AI literacy there, but then really, helping the patients is kind of the next piece that is necessary for a lot of these technologies. So kind of being out ahead of that is always
Yeah.
a good thing. So that would be a lessons learned.
That's brilliant. The idea that transparency is gonna bring it's something you should do, but it's gonna bring questions, and you should be ready for those.
Absolutely.
Excellent. All right, Dr. Patel, I wanna thank you so much for your time today. It's always a pleasure to chat with you, and I hope we can catch up again down the road.
Thanks so much for having me.
Have a great day.
Thanks, you too.